Hey there, my name is Jacob O'Brien, and today I'll be presenting on the application of machine learning to predict 30-day hospital readmissions in patients with atrial fibrillation. So to begin, atrial fibrillation, or AF, as it's seen throughout this presentation, is the most commonly sustained cardiac rhythm disorder. It's estimated that throughout the world, 33.5 million individuals are affected. And the prevalence of atrial fibrillation is expected to increase by twofold by the year 2050 in the US. It's also expected that there will be an increase in medical costs to treat these patients with atrial fibrillation. In 2006, the total annual cost for AF treatment in the United States was $6.65 billion. So atrial fibrillation is characterized by rapid, irregular, and chaotic electrical activity in the atria of the heart. In patients, it can cause palpitations, shortness of breath, effort intolerance, and fatigue. And it is also related to an increase in morbidity and mortality from heart failure, stroke, cognitive impairment, etc. So a well-established treatment option for atrial fibrillation is catheter ablation. And how this works is radiofrequencies or cryotherapy is used to isolate the pulmonary veins and ablate the arrhythmia foci. And catheter ablation can result in improvement of atrial fibrillation symptoms, including improved health-related quality of life and lower the risk of death, stroke, and dementia. Also, catheter ablation is more effective in relieving atrial fibrillation symptoms than antiarrhythmic medications. So the Hospital Readmission Reduction Program, also known as HRRP, was developed to reduce healthcare costs and improve the quality of healthcare within the U.S. health system. And how it works is it penalizes healthcare providers for high readmission rates in patients. So 30-day admission rates for AF patients undergoing catheter ablation is currently around 10%, or about out of the 100 patients that will come in and receive catheter ablation for their atrial fibrillation, about 10 will return within those 30 days to the hospital. And readmission in AF patients is due to atrial fibrillation reoccurring, atrial flutter, and also can be due to procedural complications. So atrial fibrillation patients are 3 times more likely to undergo multiple hospitalizations and spend 73% more annually in direct medical costs than other patients. And now onto our material and methods section, data specifically. For this study, data was used from the 2013 Nationwide Readmissions Database, or the NRD. And the NRD securely tracks patients in select states and their hospital stays. Target population was limited to inpatient discharges treated at community hospitals that were not long-term or rehabilitation facilities. In 2013, the NRD, the National Readmissions Database, was constructed from 21 states that contained geographically dispersed information, and it comprised 49.3% of the total US population and 49.1% of all US hospitalizations. So the outcomes, the primary outcome for this study was to observe the 30-day readmission status of atrial fibrillation patients undergoing catheter ablation. 30-day admissions were defined as an admission that had at least one readmission within 30 days of hospital discharge after the catheter ablation treatment. Demographics. The demographic variables for this study included age, the number of unique chronic conditions, the diagnoses of the patient, the procedures reported for a patient on their discharge, the patient's length of stay in the hospital, the patient's gender, the patient's income, and who the primary payer was for the hospital visit. Both weighted and unweighted prevalence estimations were calculated for the demographics to nationally represent selection probabilities from all 50 states and reflect the national population. So for the data processing, patients were identified with the diagnosis code for atrial fibrillation, which in the NRD was 427.31 as the primary diagnosis, and the procedural code for catheter ablation, which in the NRD is 37.34, as the primary or secondary procedure for that patient during their visit. Patients under the age of 18, patients who had died during hospitalization, or patients who had a missed length of stay were excluded as our data was collected. Also, patients discharged after November were excluded to account for the 30-day follow-up, and that this data would not be available from the 2013 NRD. Patients with procedural codes showing prior or current pacemakers or implantable cardioverter defibrillators were also excluded to ensure the purity of this data. And patients with secondary diagnoses of some other types of arrhythmia were excluded as well for the same reason. Now into variable selection. Nearly 2,000 variables were present within the database of the NRD. The top predictor variables were chosen based on relative variable importance using random forest, a well-used tree method for variable selection. And how this works is random forest identifies a small number of relevant predictors, resulting in a more precise model, but with a similar predictive performance to a logistic model. And by using random forest, the top 30 variables were identified from these over 2,000 within the database. So as we come to table 1, you can see the description of the top 30 features and variables that were selected by random forest. Going through some of these, they are age, as the patient's age in years when they're admitted, the total hospital discharges that a patient has experienced throughout their lifetime, the total number of diagnosed conditions for the patient, the total number of chronic conditions the patient has, the length of stay in days in the hospital, the number of procedures that had been documented upon the patient's discharge, their gender. And throughout the rest of this, you'll see the time of the year that they were discharged, different comorbidities with other conditions that the patient could have, where the hospital was, the type of hospital, and even the size of the patient's bed. And so I'll move on, and I'll give you just a second to look over those a bit longer. So machine learning. In traditional statistical approaches, one must build a model and then input the model into a computer. This model-driven approach heavily relies on assumptions about the shape of the data that may be prone to bias or error due to the human making the assumptions. But the goal of machine learning is to perform pattern recognition in order to learn and output a model of the data. So instead of starting out with an assumption about the data in the model, machine learning inputs the data directly into the machine, and we're able to learn from this. So supervised machine learning was used for the analysis of our data that we had collected. K-nearest neighbor, or KNN, support vector machine, or SVM, and decision tree classifier were used, and you'll see these later. To account for overfitting, the data was randomly split into 60% training sets and 40% test sets. And models were applied to both sets, and their accuracies of both sets were recorded. We aim to keep the difference of accuracies to 7% to avoid overfitting of the data, and model parameters were adjusted when the data was overfitted. So the results. After applying diagnosis and procedural exclusion and accounting for index admission and death, 5,872, or weighted 12,634 cases were included. Now moving on to table 2, which shows the demographic characteristics of 30-day readmissions. And the number that you'll see within the parentheses below is the unweighted values. So the average age in years was about 65 years old with a standard deviation of 11.6 years. The number of chronic conditions had a mean value of 5.2 with also a large standard deviation of 3. The number of diagnoses, a mean value of 8.2 with a large standard deviation of approximately 5. The numbers of procedures was between 3 and 4, and the length of stays for these patients was about 2.5 days. Now looking at the gender below, we'll see approximately 8,000 were male and about 4,728 were female. Looking at the income, you can see it's fairly well distributed, with the 0 to 25th percentile being the lowest at about 20%, and the 76th to 100th percentile about 30%, and the 26th to 50th and 51st to 75th just in between. The expected primary payer, the majority of the time, was Medicare, with some Medicaid and quite a large amount of private insurance, and very little with self-pay, no charge, and a little bit of other. So results random forest selected the top 30 features for determining the likelihood of a patient being readmitted for atrial fibrillation, with the patient's age as the most important feature, as we'll see more below. So moving on to figure 1, we can see the relative importance of the top 30 features in predicting the 30-day hospital readmission in atrial fibrillation patients undergoing catheter ablation. We can see number 1, we have the age of the patient. Just after that, total hospital discharges that the patient has experienced, the number of diagnoses the patient has, the number of chronic conditions the patient has, the length of stay, the number of procedures completed, and then the gender of the patient. And as we move along the graph, there are several other features that we had identified earlier as those top 30, but the most important being those discussed before. So continuing with results, performance of machine learning classifiers can be described using accuracy, precision, sensitivity, specificity, and area under the curve, or AUC. We decided to use accuracy as the key performance indicator, as the total number of correct predictions out of all predictions was the interest of this study. And accuracy refers to the total number of correct predictions out of the total number of predictions made, just what we were looking for. Of the machine learning methods, KNN, or K nearest neighbor, had the highest accuracy at about 85%, followed by decision tree classifier at about 78%, and SVM at about 61%. And you can see those in this graph form on this, with K nearest neighbor as the highest in all categories, including accuracy, precision, sensitivity, specificity, and area under the curve, followed by decision tree classifier in the middle, and then the lowest being supported vector machine on the far right. Discussion. This study aimed to predict 30-day readmission status for atrial fibrillation patients undergoing catheter ablation. Machine learning models were able to accurately predict the occurrence of 30-day readmission at about 85% accuracy. And just as stated before, the top predictors included age, the total discharges from a hospital, the number of diagnoses a patient had upon discharge, the total number of chronic conditions the patient had on discharge, the number of procedures the patient had on record, the length of hospital stay, and the patient's gender. The limitations of this study. One limitation of this study is the cross-sectional nature of the 2013 NRD data. Healthcare references and tools such as the ICD manuals have been updated since the collection of these data. Using data from multiple years would allow development of potentially more accurate predictive models, and future studies may be considered collecting longitudinal data to model prediction and confirm the results. And that's something that we plan and hope to do and hope that others can do as well. And to end our discussion, previous research indicated that older age, various comorbidities, gender, length of stay, and number of chronic conditions as top predictors for 30-day readmissions, and this is consistent with our findings. Our study was able to further identify additional top predictors, such as total number of discharges in the hospital, number of diagnoses a patient had on their discharge, and the number of procedures a patient had on their discharge. These were all missed by previous research studies that had used traditional statistical approaches, and we believed that using machine learning, we were able to identify these others. Thank you for listening today, and I hope you've enjoyed this presentation.